done?
Good? Hi, everybody. Thank you for coming. My name is Sarah, and I'm the president of Students for National Health Program here at U of L. I have the pleasure of introducing our speaker who's traveled further than most to speak to us today, Dr. Gerald Friedman. Dr. Friedman graduated from Columbia College in 1977 and later attended graduate school at Harvard, where he earned a PhD in economics in 1986. Since 1984, he has taught economics at the University of Massachusetts-Amherst. He has written widely about economics and the campaign for improved Medicare for All, including his 2013 study entitled Funding the Expanded Improved Medicare for All Act, How We Can Afford a National Single-Payer Health Plan. He has drafted economic analysis of state programs in Massachusetts, Maryland, Colorado, Pennsylvania, Rhode Island, Oregon, New York, Washington, and Ohio, as well as for the United States. And he's currently working on a book, The Case for Medicare for All. Dr. Gerald Friedman.
Thank you so much. Yeah, I came from Massachusetts, which is known for being cold and unfriendly. And I come from Kentucky, which is friendlier than I would have thought. You don't believe the dinner I had last night getting off the plane. It was so sweet. So thank you all very much for having me. The book, I'm not working on it anymore. It's done. Coming out in January with Holiday Press. Go buy it as soon as you can. Okay, we're going to talk about how the U.S. healthcare system compares with other countries. How bad are we really doing? How healthcare finance with competing insurance companies affects care provided, makes it worse. And how improved Medicare for All would work, how we could afford it, and how it would affect your lives and conditions. Okay. How we compare. I'm always telling people that if you get nothing else out of anything I say, then remember this graph. It tells you everything you need. Each diamond here represents a country, a member of the Organization of Economic Cooperation and Development. In graduate school, we called this the Club of the Rich. When I mentioned it in my big lecture class with 800 students, I tell them anybody who can tell me where it came from, the OECD gets extra credit, and I'll give you a chocolate. It grew out of the Marshall Plan. Anyway, these are the rich countries in the world. Here's our spending in logarithms on healthcare. And here's our life expectancy. So over here, you have Japan, which has the highest life expectancy in the OECD. Japanese go to the doctor 12 times a year. But the healthcare system is about half as expensive, remember this is laws, as what we do in the United States. Here's the United States. We are an outlier. Nobody comes within 50% of what we spend. But our life expectancy is a little more than Chile and a little less than Peru. At this point, I usually ask, would you want $7,000 per person, or do you want the 6 years? You know, the gray hairs in the audience will usually say the 6 years. The students paying their college debt, they want the money. You know, you can decide for yourself. But we should get one or the other. And what's more, it's getting worse. Here's the OECD aggregate life expectancy. It's been moving up steadily. You know, Robert Gordon and some other economists say, oh, it's all clean water. Well, not quite. You know, everybody had clean water back in '95. Maybe it's the long-term legacy of clean water and better nutrition, or maybe what you guys are learning to do actually makes a bit of a difference. And here's the United States. Yeah, we're gaining, actually, you keep going, we drop off a little bit. We've actually lost a little ground in life expectancy. But the point is, the gap is getting bigger. Whatever we're doing that's different from what everybody else is doing is making things worse. Here's our physician consultations. Maybe this has something to do with it. The average for the OECD is 6.6 visits to a doctor per year per person. The United States is a little more than 4. Like I said, the Japanese, who live the longest, they go 12 times a year to the doctor. Experience barrier of cost. Barrier because of cost. That's not the best word. In the past year. About a third of Americans report that they did not do something to take care of their health because of cost. Now keep in mind that about a third of Americans did not go to a doctor at all because they were perfectly healthy throughout the year. So about half of those who had an issue did not go to the doctor because they could not afford it or did not fill a prescription. Not going to a doctor, okay, probably you're going to get better anyway, so that's not a good idea, but not filling a prescription? You went to the doctor said, you've got a problem, this might help, and you didn't fill the prescription, or maybe even worse, you spread it out. Diabetes patients who can't afford their next insulin, so they spread out their insulin over time. You know what we call people who do things like that? Dead. And this is where it shows up. Each diamond here represents a county in the United States. Some counties are pretty small, don't have survey data, so I've got about 3,000 counties here out of 3,300 in the United States. I couldn't use data for the rest. The vertical is age-adjusted mortality. So adjusting for the age distribution of the population, what is the mortality rate? And here is the proportion reporting cost access problems. This is from 1912. The cost access problems thing has actually gone up. It went down briefly after the ACA and it's been going back up. The regression line, I give you the equation here. Upward sloping, R squared is about a third. About a third of the variation in age-adjusted mortality in U.S. counties is associated with this one variable. Could you afford to go to a doctor when you were sick? I don't show it here because I just wanted a two-dimensional graph, but being black is associated with high mortality. Being in a state with a Republican governor and Republican legislature in 2014 is elected 2014 is associated with high mortality. Lower income is associated with high mortality, but it doesn't change this variable. Insurance is associated with high mortality, but when you include it in a multivariate regression with can you go to the doctor, can you afford to go to the doctor? Insurance doesn't matter. Insurance is a means to an end at best. Having insurance helps you go to a doctor, you live longer. Not having insurance, you can't go to the doctor, and it's because you can't afford to go to the doctor. Having insurance and not being able to go to the doctor because of co-pays and deductibles, the insurance doesn't help. Here's Kentucky. These are counties in Kentucky. Almost as high in R squared. I mean, there's variation around this line, but it's upward sloping, statistically significant. If you can't afford to go to the doctor, you are more likely to die. And it accounts for almost a third of the variation in mortality across counties in Kentucky, as it does for the country as a whole. What's more, things are getting worse. As you know, and this is a very popular topic in economics, of course, higher income over the last 30 years has almost gone entirely to rich people. Actually, I keep to update that. That's almost 50 years now. Since the early 1970s, we've had rising inequality. That rising inequality combined with the changes we have made in our healthcare finance system are making inequality in life expectancy worse. Most of the gains for men and all of the gains for women have gone to wealthier people. In fact, 40% of American women, the poorer women, this is from an article in the Brookings Papers on Economic Activity, 40% of American women have shorter life expectancy than their older sisters did 20 years ago. The first time I gave this, it was in Oregon. I remember very well. I showed a graph like this. And I said, what on earth could be going on? And afterwards, a woman who works at a food bank came up to me and told me something that was so obvious I was embarrassed. If, because of welfare cutbacks and whatever, you don't have enough money for food for everybody, who eats in the family? The children. No mother is going to eat while her children are going hungry. So when income goes down, the canaries in the coal mine for the failure of our economic and healthcare system are mothers who cannot afford to eat because the economic system and the healthcare system is not working. Who doesn't get the prescription filled? Mom. The kids' prescriptions will be filled if they can manage at all. They'll take the kids to the doctor if they can manage at all. You know, maybe the husband will go to the doctor because he earns more money. They have to keep him healthy. Mom is the loser, and that's what shows up here. Poorer men aren't gaining as much also. Things aren't great for men, but they're really, really bad for poor women. Okay. Our healthcare finance system interferes with providing care, and things are getting worse. Okay. This is what, back in 1982, I was in a seminar, Richard Zeckhauser, in and out of Washington, head of the Kennedy School of Government, came in and talked to us about what we need to do in healthcare. Martin Feldstein came by, also in and out of government, professor at Harvard, head of the National Bureau of Economic Research, said the problem with healthcare is people don't have what we can now say skin in the game. They're not paying for healthcare on the margin, so they abuse the healthcare system. Zeckhauser said healthcare is a waste, it's a consumption activity, it does nothing, and we should discourage people from using it. From abusing it, I should say, his word, abusing it. Going to the doctor. Grandma goes to the doctor when she's lonely. Well, if that's what you think, then what you want is to put in programs that will raise the cost of going to the doctor, so people will be paying more for it. I mean, if we want people to stop burning oil and fossil fuels, we should be raising the price. Fortunately, Zeckhauser and Feldstein would agree with me on that one. They want insurance market competition, encourage insurance companies to compete with each other with the idea that they will drive down costs. They want more utilization review. You know what that is. That's where the insurance company tells you not to give this prescription to a patient, or not to send a patient to a specialist, or do a scan, because, oh, that's just a waste. And you doctors don't know what's sufficient. They want higher co-pays and deductibles so people won't go to the doctors. And the result has been all these have failed to control costs. They've probably made costs worse while undermining care. And we'll go through them. First of all, get insurance companies to compete. They don't compete by becoming more efficient. 50% of your costs as a health insurer are incurred by 5% of your people. What's the best way to lower your costs and increase your profits? You could become more efficient in bill processing. That may lower your costs by 1 to 3% if you're really good. About 5% of your costs as a insurance company or bill processing, so you can't do much more than that. Or you could find the 5% of the people who incur 50% of what they call medical losses. That's what insurance companies call spending money on health care. We should call it the care ratio, the proportion of spending that goes to health care. They call it the medical loss ratio. Find the 5% and get rid of them. That's lemon dropping. You get somebody like me. I take statin, I take 2 blood pressure medications, I've got terrible arthritis here, I've got disc damage. Get rid of me. Get me to go to a different insurance company. Or get me to die, for heaven's sakes. Whatever it is, just get me out of their pool, and they'll immediately save money. Get more people like you. I don't mean to be presumptuous, but you're a cherry. Cherry pick. Get the healthy young people and get rid of the lemons. Find the 10% who incur 70% of your costs, get rid of them. And suddenly, God, you could lower your premiums and raise your profits. And that leads to the second thing. They say, well, the insurance companies could compete by driving down provider prices, controlling prices at places like Massachusetts-General Hospital. You've all heard of Massachusetts-General Hospital. It's my favorite whipping boy. 2 years ago, I was invited to Coconut Grove, Florida, to address a meeting of the CEOs of America's research and teaching hospitals. I was to address them as part of a debate with Zeke Emanuel. They didn't know it, but Zeke and I were co-teachers at Harvard on a course on social theory. We didn't get along then either. So I saw Zeke beforehand, and I went up to him and say hello. Zeke with a high chin. Turned away. I thought, okay, this is going to be fun. Anyway, I brought up Massachusetts-General Hospital and Partners Healthcare again and again, and afterwards the head of Partners came up to me to bawl me out. He said, we're not a monopolist, we have only 20% market share. Good enough. But anyway, this is what's happened to hospital prices. This is a study in California. It's the easiest one for me to find. I was being lazy. Don't worry, this is nationwide though. Since 2000, you all know what's been happening. Hospitals have been consolidated. Elite hospitals like Mass General have been buying up other hospitals. And what else have they been buying? Physician practices. In 2000, about 1/3 of American doctors worked for somebody else. Now, 1/3 are independent. 2/3 work for somebody else. And that ratio is rising. My doctor used to be independent. Her practice was bought up by Partners. The first neurologist I saw about my neck, Partners doctor. The second one, well, actually it's the fifth one, is independent. And I talked to him about it. Why are you still independent? And he said, well, we think about it a lot because Partners has offered us a lot of money. But we value being able to control our own destiny and handle our patients the way we want. And we're giving up a lot of money, he says. He didn't give me the numbers, but we're giving up a lot of money to remain independent. Well, how is it that, and Partners will say, they say that they lose $70,000 per physician. That's what they say. Yes. So we're not trying to be a monopoly. Well, why do they buy them if they're going to lose money? Because they make the money by steering people to their expensive hospitals. Partners charges for the same procedures. There was a study by the Massachusetts Attorney General, this is 8 years ago, and she lost election to the Senate and then governorship, partly because she did this study. Partners charges 4 to 5 times as much for the same appendectomy, the same tonsillectomy, the same procedures. They'll charge, according to somebody who's director of emergency medicine at Cambridge Hospital, they will charge 5 to 6 times as much for the same MRI. Even though, you know who's reading that MRI? A radiologist in Bangalore, India. The same one. He also said that if they do the MRI at Cambridge and put the person in the ambulance, send them to Mass General will throw away the image, the CD, and do it again, just so they can charge. Here's what's been happening in crisis. This is people doing single-payer campaigns for Medicare for all have been a little behind the curve on this. Everybody's been behind the curve. How much of our healthcare spending is now going in inflated prices to hospitals? And what are the insurance companies doing? Not a bloody thing. We saw this in Massachusetts. The head of Tufts Health Plan, one of the state's 8 insurance companies, James Roosevelt, grandson of Franklin Roosevelt, he said, we're not going to put up with it anymore. We're going to go to partners and tell them you're overpriced. He did, big splash in the newspapers. The next day, 48 hours later, he surrendered because partners is too important. You could not go to your subscribers and tell them you're not going to be able to go to a partners hospital. You know, the Harvard teaching hospitals are in Massachusetts. Of course you have to go there. Relative price of prescription drugs in the United States, and this is a few other countries. Every one of these drugs more expensive in the United States, although we don't have data for a couple of the countries, for 2 of the drugs. Acid reflux, if you prescribe this in the United States compared to the Netherlands, your patients will be paying 9 times as much for the same drug manufactured in the same factories. If you compare to the UK, 5 times as much. Cancer drugs, everything, is more expensive. According to the Trump administration, whose Department of Health and Human Services is run by an Eli Lilly executive, they say drugs are twice as expensive in the US. You know who saves money on drugs in the United States compared to the rest of us? The Veterans Administration. They pay 40% the price that the rest of us pay for drugs on average, because they are the only agency of the federal government that negotiates drug prices. I can tell you about my experience in Florence, Italy. Ask me later. Okay, diabetes prices in the United States. If any of you have a relative who's diabetic, this cuts close to the bone. How much more expensive it is. Insurers do have a strategy to resist high provider prices. They say, okay, we'll fight to bring down inflated prices. We'll set up networks, and we'll only let you see doctors who give us lower prices. And then every year we'll renegotiate the networks. I mean, this is the way economists recommend things. If I don't like the price of coffee that I'm being given, I'll find somebody else, and then I'll go back to the first one and negotiate. Your bargaining leverage depends on your ability to walk away. So you have to be able to tell doctors and hospitals, we won't send you patients. Well, what happens to your people if they can't see the same doctor? Everybody knows, and it's been shown many, many times, that the relationship between a patient and a physician is vital to successful treatment. You have to know your patients, and your patients have to know you and trust you. And what's more, every time your patients change, every time you change networks, your patients lose, but every time your patients change jobs, they have to change their insurance, and they change their networks. So the economists who have recommended things like this, they are treating doctors like you are automatons. That there's nothing special in your human relationship with your patients. So you're interchangeable. We can change you, move you around. One day we'll use you, another day we'll use you, and it's all the same. Okay, and then of course there's utilization review. You know, this is an extreme example of, I had to sign my name 11 times for physical therapy for, something. And when I went to, I handed on all this paper, I told the person, you know what? You physical therapists, you're owned by partners. My doctor's owned by partners. My specialist is a partner's doctor. Why do I have to sign my name 11 times and fill out all this paper again and again? How come your electronic medical records don't talk to each other? So I used this when I was talking to the hospital people. And afterwards, the Mass General guy, after yelling at me that he's not a monopolist, he said, by the way, we're getting the Epic system online and all of our people will be able to talk to each other. Have you dealt with the Epic system? Partners alone spent over $1 billion on it. One of my colleagues in computer science worked for Epic, consulted, visited that campus. You see where the $1 billion went. Did it go into a high quality system that can talk to anybody and give the easy information? I rest my case. Okay. So you decide you're not going to do this. You're going to be a nice insurance company. You're not going to bother people. Look at all the things you're going to say. And this is the standard. Of course they've got a ton of money that they're spending on this stuff. They're spending all this money on utilization review, on paperwork, etc. What's the purpose? Drive away sick people. Drive away doctors who overtreat sick people. Discourage doctors from sending patients for specialists or for other testing. You're going to have to fill out all this paperwork. You're going to be spending an hour on the phone to some snot-nosed high school graduate in Omaha who's going to tell you how to treat your patients. You'll say, maybe they don't really need it. Or if you do persist, you're going to burn out and you'll drop out. And just like the insurance company would be fine with me dying, it would save them money, they'll be fine if you drop out of medicine and get replaced by somebody who doesn't treat their patients carefully. Okay, what happens when people don't get the needed care? These are links to various articles. I'm happy to send anybody my PowerPoint or whatever. Patients with COPD, if you're in a high deductible health plan, you end up spending more money because you end up having more frequent ER visits and hospitalization because you don't get the primary care. Women with breast cancer delay diagnostic testing are more likely to die. Low-income women especially, if they have a high deductible health plan, they don't go to the doctor, they can't afford the more expensive treatments, they die. Diabetes, they use less medical care, high deductible plans, they often end up being more expensive. So, how would improve Medicare for all work? Well, this is, the blue line here is the current system projected by the Center for Medicare and Medicaid Services. This is what we'll be spending per year, from $33.6 trillion. I have to remember the T. In 10 years, we'll be up to $6 trillion. Medicare for all, improved Medicare for all. Now, not everybody agrees with my estimates. And I'd be happy to go over them a little more. But my projection is we'd be saving about $700 billion net in the first year. And we would slow the rate of growth. Because remember, what have been the drivers of high inflation in healthcare? Rising hospital prices, rising drug prices, coming from the monopoly power of these providers. Control those and you will slow inflation in healthcare. I project a 1.1% slowdown in the rate of inflation in healthcare, which would bring the US to the Canadian inflation rate. Here's where we get the savings. We have savings on administration in the provider offices, $2 trillion over 10 years. This is over 10 years. We control inflation in the healthcare sector, $2 trillion. We have $6 trillion saved in insurance administration. Instead of, 20% of your insurance premium goes to administration. Almost all of that is above and beyond what is needed to administer the Medicare system. Medicare is administered at 1.6%. In my projections, I use 2% because my friend Zeke insists that Medicare is under-administered. They don't do enough fraud prevention. So I'm putting extra money in for fraud prevention while not counting any savings from that. And then the biggest is prices. Drug prices and hospital prices. We could save $8 trillion if we brought those down to more rational levels. We'd be spending more money. Just to make things complicated, this is 1 year, not 10 years. Removing barriers to access, increased utilization. If any of you followed the Urban Institute, they make a big deal about increased utilization. To me, this is a benefit because more people will go to the doctor, they'll be healthier, but we'll count it just as a cost here. $182 billion for that, $67 billion for covering the uninsured, $112 billion for picking up Medicare premiums. We don't have to do that. And then additional government administration because we're on the big program, and Medicaid rate equalization. Doctors who treat Medicaid are under-reimbursed now. How would your lives change? Financially, time management, and spiritually. I'm an economist, but my daughter's a Buddhist, so you think about the spirit. My wife's kind of a Buddhist. And I'm a Jewish economist, so we're kind of, Okay. Finance first. We lower your rates by about what you'll be saving on reduced billing and insurance. That's how we're going to capture those savings. We'll raise rates for Medicaid. So if you want to treat poor people, or underserved communities, then go right ahead. You will be paid as much as my doctor in affluent Northampton, Massachusetts. And you're going to have more volume because you're not going to be wasting so much time dealing with insurance company paperwork. So you're going to be able to treat patients again. Overall, we project $37 billion in administrative savings, reduced market power, some of what the hospitals are getting will go away from you. Increased utilization. You're going to have more time to deal with patients, and you're going to be paid for that. And if you're treating Medicare. Overall, I project improved Medicare for all will lead to an increase in revenue for physicians. Balancing it out. Increased revenue. At the same time, you're not going to be spending so much. So the benefits are even greater, financial benefits for you. Of course, all the time. 16% of physician time now is spent on administrative tasks. At least 8% on billing and insurance-related activities. And there's burnout. How many doctors, older doctors who know, experience this? That they are just spending so much time dealing with the insurance companies, and they just want it to go away. It is insulting. I don't know how many doctors I know have told me this. It is so insulting. You go to all this training. You learn to be a physician. You go years and years of schooling, and then they tell you what to do. Contribution to physician burnout. The AMA reports 44% report feeling burned out. 59% of those 44% bureaucratic tasks. Electronic health records, 32%. Hours of work. Physicians work too much, especially work too much on bureaucratic tasks and electronic health records. My physician reports that after she puts her kids to bed,
I don't know how she does it. She grew up 2 houses over. We've known each other since she was a child. But anyway, she has 3 children, and she is a full-time physician. And after she puts them to bed, she goes back over her reports and fills in all the extra blanks. Because the insurance companies want all these blanks filled in, all these questions answered. Why? It's like, does she need to report that I don't have diabetes? I don't have diabetes. No question. They don't need to test for it. They don't, but she has to answer that question. Because if she doesn't answer that question, the bill will be sent back. It won't be paid until she fills out the records properly. That's the EPIC system, by the way, because she works for the partners. Okay, lack of respect from administrators. This people works for somebody else. Insufficient compensation is not as important as lack of respect. I mean, compensation is important. People want to be paid adequately, but they want respect as well. And then we go on. Hours spent per week. A third of doctors report spending 20 hours or more per week on paperwork. It's ridiculous. Okay, spiritually, be free to practice medicine again and help your patients. I mean, I know some people do things for all sorts of reasons. Some people become economists for the money. Some people become economists because they want to help the world. Some people become doctors for money. But a lot of the doctors that I know got into the practice of medicine because they wanted to help people. They didn't do it because they wanted to help an insurance company lower its medical loss ratio. The most challenging part of jobs for physicians, this is from a recent survey, a quarter of them, 16% working long hours, which is related to the bureaucratic stuff. 15% difficult patients. You're all going to experience this. I get students who are difficult. They come in my office to complain about their grades. It's like, ugh. 13%, the most challenging part of the job are the goddamn electronic health records. 27% rules and regulations, having to fill in the damn blanks on the electronic health records. 12% getting fair reimbursement. Money matters. Money's important. 3% of doctors report that nothing is challenging. Those are the lucky ones. Or the drugs. Most rewarding part of the job, 27% gratitude and the relationship with your patients. I know that, I always try to say thank you to my doctor, always have. My previous doctor, who dropped out, burned out after electronic health records, he went to college where I went a couple of years ahead of me, and we're friends with the synagogue. He held the Torah from one of my daughter's bat mitzvahs. Gratitude in relationship with patients. What is most important in my job? I mean, I love doing talks like these, but a student gave me a thank you card 2 weeks ago and a bag of M&Ms because I give out chocolate in my large lecture classes. So he said, I think you should get some chocolate. That made my week. I've got a box where I keep all souvenirs, mostly from talks like this or whatever, but I also throw in notes from the students and things. So, being good at what you do. You want to do the right thing. I don't know anybody in the world, even the most greedy, selfish person, who wants to do bad work. You want to do the right thing. You want to be prescribing the drug that you think will help your patient, and the insurance company tells you to do something else. Oh, God. I mean, if the university told me to do something about my teaching, I would tell them to go to hell. And I can do it because I have 10 Yeah. Knowing that you're making the world a better place, and maybe getting some gratitude for it. And these are things that really matter to people. You know, I mean, I'm an economist, but it doesn't mean I think the only thing that matters is money. I think actually my wife, kind of like you, need to think more about money. Oh well. But other things do matter more. And I think they matter more for most physicians. And that is being destroyed in the practice of medicine in America by the insurance companies. So I left some time for the questions. I'm happy to take it. Thank you so much. And the hands up there?
Are there any downsides to Medicare for all?
Oh, yes. Absolutely. And I think we need to be cognizant of that. I mean, there's the obvious downside that there'll be displacement to many people's jobs. About 500,000 people work in the health insurance industry. And we need to do right by those people. We established, as a national policy, established health insurance. We encourage the growth of this industry. It doesn't mean we're obligated to keep it forever. And it would not be the first time that we've changed our economy. On the plane up here, I sat next to a guy from Rochester, New York, who Rochester used to be the richest city in America. They had Kodak, Xerox, and the lens company, Bausch & Lomb. Bausch & Lomb is the only one that's still around. The economy changes. So we need to make sure that they get job retraining and get opportunities to move. It will work out because the economy will expand if we take the burden of healthcare off of our businesses. We'll be able to export more bourbon from Kentucky if we don't charge as much because our companies have to pay for healthcare. There are about 2 million people doing billing and insurance-related activities in provider offices. Mass General has about 500 people, more than there are beds in the hospital. Those people will be displaced. A lot of them will just move over to other activities because more people will be utilizing healthcare. But we also need to make sure that they can have a safe landing. The other danger is one that you do encounter, that if you don't agree with your insurance company, theoretically you can go somewhere else. I mean, that's theoretical because most people, they can't afford it. You know, maybe you could find another insurance company. Most people don't have those sorts of options. So you do have to be concerned that there's a safety valve for people who feel like that they're just not being treated right, and the rules of the national insurance company don't allow them. So I don't favor abolishing private insurance. But I think that's a really small issue. The great majority of people, for the great majority of what goes on, will be treated, properly. As a democratic system in this country, I have more trust in government and even government bureaucrats than I do in the people in the insurance industry who are making money off of denying the care.
So what about specifically related to either healthcare, in terms of doctors or patients? I know the VA gets brought up a lot, for example, and I don't think you'll find any physicians or patients who are extremely satisfied.
Well, the VA is terribly underfunded. And the British National Health Service is another one where people say, oh, they've got all these problems. Well, they're seriously underfunded. Britain spends a quarter as much as we do on healthcare per person. And they should spend more. The VA has experienced a terrible crisis because, we've been at war for 18 years. And half of the soldiers who have returned from service in Afghanistan and the Persian Gulf have come back with some form of disability, accepted disability by the VA. It's not just people claiming, whatever. But no, these people with real problems that have been accepted. And the VA was not set up for this massive influx, and especially a massive influx of young people. The VA in 2000 patients there were disproportionately World War II vets. And now we have all these people coming in with traumatic head injuries, PTSD. So again, VA is having real problems, but it's because we didn't plan for it when we went to war. Prior to 2000, the VA was a model for good health care. Efficient. They were the ones who pioneered electronic health records. And why didn't partners just take off the shelf? Because it was open source, the VA's electronic health system. Why did they do that? Because the VA system wasn't set up for billing. It was set up for patient care. And Epic is set up for billing. Ooh, sorry. Okay, there are other questions. Yes?
So you've made a strong case here that the bureaucracy of doctor billing is related to private insurance policies. Medicare, Medicaid paperwork and bureaucracy, from what I've seen, can be just as difficult in terms of the way, because they're keeping costs, to keep your costs. So can you comment on that? I mean, is this a really dramatic difference? But it seems to me there's a lot of bureaucracy in the government system.
Yes, especially in Medicaid and especially in Medicare Advantage. Medicare Advantage is basically private insurance. Medicaid is increasingly privatized. But also Medicaid has its own rules and its own restrictions, try to keep costs down. Medicaid bureaucracy is about 6% spending, compared to 1.6% for traditional Medicare. And Medicare Advantage sucks up about 18%. So it's basically just like private insurance, with this layer on top of the government trying to supervise what the private insurance companies do. So Medicare and Medicaid are chasing the private insurance companies to try to lower costs. And that is, get back to the dangers, that's a danger that we'll have to keep an eye on for a national health system. That it not just be used as a cash cow to economize on spending. The whole physician reimbursement of the Medicare fiasco that goes back to 1981, I think, 84, where every year Congress had to vote this rate fix because they had set up that the rates would be slashed for Medicare. Finally, they abolished it and substituted this crazy bureaucratic system to try to control what physicians do. So we need to fight against that, even while we're bringing in a better system.
Because you'd have to dramatically, you can't just take what we're doing now and expect a bureaucracy. There has to be a bureaucratic investment to make this better for physicians.
Yes, and that's part of the $53 billion that I'll put in there for increased government administration. We'll be saving a lot of money. For example, we'll do away with the Medicaid system as an independent entity. Just integrate everybody. So we're not going to have to check for eligibility, not going to have to follow up. S-chip will go away because children will just be part of the same system as everybody. So we'll be saving a lot there. But we also, we'll have to be expanding. Like I said, we probably should do more within Medicare to check for fraud. Like the governor of Florida, the senator from Florida, Rick Scott, whose company had a $500 billion fraud. So, yes.
You mentioned that utilization wouldn't necessarily be a problem for Medicare for all. However, with the physician shortages that are happening, I can't see how there wouldn't be an influx of patients that would overwhelm physicians, at least in the short term. So could you explain kind of how that might work?
Yeah. Well, I'm figuring that the 8% of physician time that is now being spent on billing and insurance-related activity will mostly go away. So that will free up maybe the equivalent of a 7% increase in physicians, which is by itself almost enough to cover the about 10% increase in utilization I anticipate. There's a danger, and there's certain specialties, especially that primary care, family practice. There are a lot of details that we're going to have to work on in this system. We're going to have to change the reimbursement
relative reimbursements and attract more people. We probably should do, well, this may be popular, we should probably make medical school free so that physicians can just go out and practice medicine and not, you know, come out with 300, like one person was, the guy next to me, I think it was, or somebody I talked to, yeah, they knew this person came out of medical school with $300,000 in medical debt. You know, it's like,
Come to Kentucky, it's cheaper.
oh, good. I'm glad. There's probably Mass General at Harvard. But yeah, there are tweaks that we're going to have to do. Yeah.
This problem is obviously multi-factorial. There's so many moving parts of it. You know, one of which is, you know, life expectancy, the amount of money you spend on health. They're not in every country the same, you know.
Yeah.
And more importantly, wouldn't it be easier to make medical care and take it away from being a commodity and making it a utility?
That's basically what we're talking about. You'll
Because,
go to the
you
doctor.
know, when LG&E wants to raise its rates, it has to go before a committee and justify it. You have all these systems that are set up already. And we're sort of moving in that direction where we say, you know, you have to prove to us that 85% of what you're spending is inpatient care.
Yeah, that's already in the Affordable Care Act. And that the ACA did move in the right direction on some of these.
I agree with you there. I didn't want to bring up ACA because it becomes political.
Right. But yeah, no, I mean, absolutely. And I agree with you absolutely that the direction we need to move in is treating, I mean, if I had my druthers, I would adopt something like the National Health Service. But yeah, I don't think we're going to do that, and that would be an even bigger change than what we're talking about. So this is big enough. But the idea is that we do need to think about health in a more encompassing way. Healthcare is part of it, but when people have diabetes, then we also need to think about their diet. And asthma, we need to think about clean air. It's estimated that in Los Angeles Basin, life expectancy has increased by 4 years because of the Clean Air Act. You know, there are ways that we can raise life expectancy by more outside of healthcare. But insurance companies, and spending in insurance companies, they can't think that way. They have to think in terms of just health care for the people they have for the 1 year. If we have a national system.
There's no money, there's no gain in wasting money on teaching people how to be healthy, because next year they might not be in your program.
Exactly, but a national system, there we go. Okay, thank you very much.